All right, it should be, thanks a lot, folks, but I would say it should be a rule that no one should follow Guggen, because the cases are just so incredible, unbelievable. Last night I said the same thing. It's just unbelievable. So that being said, I'm going to go in a different direction. So the topic was my best case in last year, but rather than trying to go through and really go through some oohs and ahs or maybe even the complication rescues, this was a case where I think emphasized something more than just being complicated. It emphasized team, and I think it's important. So I want to show this when I'm going forward. I'm not sure what happened with that slide here, but let me see if right there's my disclosures. And we're going to go to the background. So best cases are not always ones where you're using the latest and greatest or performing off-label complication saves. Rather, great cases can represent a challenging anatomy necessitating a collaborative approach. So I'm just going to give you the history here. We have a 68-year-old male with a recent history of CABG at an outside hospital. 4 days post-CABG, he developed a DVT and a subsequent CVA, arm weakness with slurred speech. No history of AFib documentation, and he was in the hospital, so we had it on telemetry at this outside hospital. There was no AFib documented. No prior history of DVT or clotting issues. Had an echo, which revealed the presence of a PFO with shunting. DVT CVA. So we're in a situation here where the patient obviously has an acute embolic issue, secondary, most likely to the DVT. So start on oral anticoagulation therapy. Within 1 day of starting the therapy, he developed a massive GI bleed and was transfused over 10 units during his hospitalization. He was evaluated by GI and found to have gastric ulcerations. They decided to hold the oral anticoagulation. An IVC filter was placed, and the patient was discharged from this hospital 2 days later. His CVA symptoms had resolved, and again, they thought the family was doing well, but 1 week later was back in the emergency room for swollen legs, scrotal swelling. Imaging revealed an occluded IVC filter with bilateral occluded iliac, common femoral vein, popliteal veins. So it's a tough situation that the gentleman's in, and again, he was seen at an outside hospital ER at this point. The patient was initially turned down by outside facilities, 2 of them actually, for his lower extremity venous thrombectomy, secondary to concern that any lysis or thrombectomy could result in a repeat GI bleed, worsen intracranial hemorrhage, or a new CVA from clot crossing over the PFO. So really, people were saying, sorry, you know what, at this point, let's just kind of hold our, bite our lip a little bit and try to see what we can do. He was evaluated by GI again, and no bleeding was identified, and there were no new ulcerations. So he was started on anticoagulation therapy again, thinking maybe that's the best therapy at this point because nobody wanted to actually do any invasive procedure. He was discharged, but the problem is his edema and pain continued with progression of symptoms and going towards phlegmatia at this point. He was actually readmitted to our hospital. So he came in, and he was seen by our interventional radiology team. They felt very strongly to address his venous issues given his continued symptoms, and his legs were swelling even worse. And this is a situation where now risk-reward comes into play. But they wanted his PFO addressed first before any mechanical thrombectomy was performed, and the concern was access. So the fact is, oftentimes people say PFO closure really should be routine, shouldn't be that difficult. Well, again, I think you have to think about what is a PFO compared to what an ASD is. The PFO, again, isn't the same thing, and I'll show you here in a second here, but the patient underwent a TEE. The presence of the PFO with a long tunnel was revealed. There was no left atrial clot, and there was no evidence of AFib on any of his prior or current hospital visits. Very important. Remember, he's post-CABG. My thought was, well, listen, that PFO has been around for a long time. How do we know this wasn't caused by something else with the CVA? So if you look here, the imaging here on the T can show you that clearly there's a presence of a PFO, and there's a tunnel obviously as well. And the next shot here, and I'd like to move this forward, and let's see if I can get to the next slide. There you go. And you can see the color jet across that PFO as well. So it's clearly there. And at this point in time, no brainer, okay, he's got it. So the main issue is how do we address it? So how did we close this? Decision was made, given his worsened symptoms, to proceed with PFO closure. This is where, during this conference, we oftentimes talk about phoning a friend, but I didn't want to phone a friend during the case or during a complication. I decided to say, listen, there's certain things I do well, there's certain things I don't do that often. And coming from an alternate access for PFO closure is not something I do routinely. So I actually called Dr. Farbach from Interventional Radiology, Dr. Farouch Burgess, who is a congenital and interventional cardiologist, and my echo specialist, Dr. Ware, about coming together. And we discussed this case. We sat down and we said, what's the best way to approach this before getting the patient on the table? I also had my CT surgeon, Dr. O'Hare, who presented earlier this morning about the patient's recent CABG and is an endovascular approach the best thing? So the thought process was, if we could do this endovascular, we should, but we should really come up with a couple of plans in case one option doesn't work. And obviously, we need to generate anesthesia and TE guidance, which normally with PFOs you really don't. So the fact is, we decided to go with the right IJ vein access was easiest to enter and close. But again, crossing a PFO from the neck from superior is not easy, and I'll show you that in the next slide. Transhepatic access would give us a straighter view to cross a PFO. However, access closure could be an issue. Again, we would need vascular plugs and coils. I'll tell everyone here in this audience, I'm sure everyone's seen gymnastics, and the thing is, when you watch a gymnastic routine, you see someone jump in the air 12 times, flip everywhere. If they land on their butt, the score is 0.0. So what I'm trying to say is, you need to stick the landing. So a long time ago when we started doing TAVR, we always were happy about putting a valve in, and then would have an iliac on a stick on the way out. That's not appropriate. You need to be able to get out of the patient safely. So the fact is, when we looked at this, even though putting a coil in the liver, sure, it can be done. The way I looked at it is, I don't want to screw up a good case with the closure. I want to make sure that that's a variable that we can take out of the mix. So traversing through a clotted off common femoral vein with a sheath past the IVC filter was an option, but it was least preferred because, again, we're trying to drill through something that's already occluded. We would have to put a filter from the neck to block anything that we pushed up. And again, there's no guarantee that we'd even be able to get through it successfully. So everybody who closes PFO, you know the anatomy. But for those who don't, remember, it's not really a hole, but rather a flap or a doorway. So if you're coming from the groin, it's pretty easy, right? The wire will sail most likely right into the left atrium coming from the groin from an inferior approach. If you're coming from the neck, you have to go down, turn around, and come back up. This is why it's not a common place to do this from the IJ approach. It could be very difficult, actually, to get access. So we decided we will do the right IJ, but we'll have the hepatic on backup. So I had everybody scrubbed, ready in the room to go for this case. 8 French access, we had IR on standby, initial catheter choice, we did a JL35 diagnostic, followed by AL1 diagnostic, with the 2 glide wire, both straight and angled. And I know what you're thinking at this point. Why didn't you just use an Agilis? True. But the truth is, we didn't at this time. But those are things I'm thinking about for the next time I do this. The fact of the matter is, it was a little frustrating. And we'll go back one. We finally crossed with an IM 6 French diagnostic catheter with a floppy choice PT wire. Everyone's happy, right? Guess what? The catheter doesn't track on an 014 wire. It was great to cross, but the catheter popped the wire out. It was too soft for any catheter to traverse. Stiffer coronary wires did not work either. So I will tell you about a phrase that I think a lot of people should understand. At this point in the case, something called tactile frustration sets in, which means you start pushing harder than you should. You start trying to really mentally will these things across. That's when you get into complications. And this is where Dr. Burgess, who is an older pediatric interventionalist, but very cool and calm, turned around and said, just relax. Take your hands off the catheter. Think about it. What else can we use? But this is the times where you just need to take a step back and say, okay, what else can we pick? Is there another option? Is there something else we should be thinking about? The worst thing you can do is keep plugging away with the same catheter and wire and cause a complication. We switched to an IM 6 French guide. Utilize a straight, soft Terumo glide wire. I'm going to tell you something. I don't know the last time I used a straight, soft glide wire. That's a really interesting kind of concept, but we used it, wire crossed, but guess what? We weren't in the pulmonary vein or the left atrium. It was in the left ventricle. Patient had already been given heparin, so we were fine with anticoagulation. I switched the guide out for an exchange catheter, a quick cross catheter, and it placed an Amplat super stiff wire in the left ventricle. Now, before you say, hey, that sounds pretty good. I mean, you got a wire, you got a straight shot from the neck. That should be pretty good, right? Well, guess what? The wire's past the mitral valve, obviously. It's in the left ventricle. So that adds another barrier and obstacle for getting a device in. So given the long tunnel, the decision was made to proceed with an Amplatzer Cribriform 25 device. Sheath was placed very carefully into the left ventricle under T guidance and Flora as well. So you can see here, the sheath is past the mitral. Now, this isn't a mitral clip case. We don't want that. I don't want a sheath across the mitral. I don't want anything there. So the goal here is, how do I now get this sheath back by deploying the device and not catching the mitral? But here's the catch. I also don't want to pop across the septum. It took me an hour and a half to cross. So the last thing I need to do is lose access. Because again, remember we talked about tactile frustration. I don't know if I would have been able to recross successfully and go through all these steps again. So this is an important facet to understand. So the sheath is in, all good, not so fast again. Pulling the sheath back with the LA disc out may catch the mitral valve apparatus. Pulling the sheath back without the disc may result in the sheath back in the right atrium. So at this point in time, this 1 minute of pulling back the sheath, you can tell here, I am basically right outside that septum. And I have now, luckily, got the sheath back, but now is the question of getting the device actually out. So at this point, we start unfurling the device. And now at this point, you can tell, okay, we're on the left side still. The ball is exposed. Should we go for it? Let's just do it. So at this point, we went ahead and deployed. Absolutely great what we saw here at this point in time. We know we're on the left and the right side of the septum. This is where it looks like, because there's a push-pull that we have to do with any type of ASD PFO closures. You guys see how difficult it is to do the push-pull from the neck. I'm not really getting a lot of response here. But the fact is, I said, we know the device is in place. Cross your fingers. Let's go ahead and release, and let's hope it doesn't move. And what we've seen here is actually, at this point, this is the release itself. It stayed in place. And there, at this point, is a color that looks across it. So this is what we attempted, this is what our goal was. And it's interesting, during the case, like I mentioned, he's a good friend, Dr. Burgess is the pediatric cardiologist. He was calming me down throughout the case or giving me advice. And I view him as like Obi-Wan Kenobi. End of the case, though, when this happened, he turned around and goes, "Holy crap, I can't believe it worked." I was like, "What?" I can't believe you didn't, but he knew if he had said any of that early in the case, I think it would have changed. Again, remember I told you about the tactile frustration? You don't want to get people on that track early in the case. So post-procedure, patient did very well with no procedure-related issues, continued on Lovenox, underwent lower extremity venous thrombectomy by IR via bilateral popliteal vein access, angiogen and Nari devices used. Awesome result. They sucked out a ton of clot from the legs, and actually his IVC filter was removed. Discharged the next day. I followed up with 1 week later, doing great. Transitioned to oral anticoagulation therapy because, again, GI had cleared him. I would be remiss to tell you that I am nervous about not putting him on oral anticoagulation because we don't know why his DVT developed in the first place. But again, his IVC filter was removed actually by IR, and he's done very well. So the conclusion here, folks, is collaboration is key. Take your ego, put it in the back seat. If you have a patient with a tough case, rather than attempting it and then calling someone, maybe you want to take a step back first and say, hey, I don't do a lot of these. Does someone else do it? Someone help me. Let's help the patient. Not sure how to do something? Again, get help and have the right equipment, because I'll tell you, a lot of Monday morning quarterbacks are saying, why don't you use an Agilis? Yeah, I know. So now we know. And again, I basically think next time around, I'll use it. Be proactive, not reactive. Thank you so much.